Okay, welcome everybody to this webinar, the EANS webinar of the Global Humanitarian Committee. So today we have an amazing panel of diverse speakers. And I will start with introducing Professor El Ouahabi, who is a professor in neurosurgery at Morocco, and he's the president of the Continental Association of the African Neurosurgical Societies. We have Professor Franco Servadei, who is located in Milan, and he is the honorary president of the WFNS and the past president of SINCH. We were going to have Professor Khan, but unfortunately he couldn't make it. But we do have Dr. Key Park, Director of Policy and Advocacy at the Program of Global Surgery and Social Change at Harvard Medical School. He's also Editor-in-Chief of the Journal of Global Neurosurgery. And then we have one of our own, Dr. Nigel Mendoza, consultant neurosurgeon in the Cleveland Clinic, London, UK, president-elect of the Society of British Neurological Surgeons, and a member of our committee. So this webinar, we're going to do a little bit different in the sense there are no presentations. So we're just going to have an open conversation and to talk about unity in global neurosurgery, if there is unity and if there's not, if we want it. So to start off, I wanted to give at least the definition of global neurosurgery, which is the clinical and public health practice of neurosurgery with the primary purpose of ensuring timely, safe, and affordable neurosurgical care. So having that in mind, who agrees that unity is needed in global neurosurgery?
Well, it seems to me we live internationally in what seems an increasingly divided, fractious international community and world with increasing nationalism. So it seems self-evident that as healthcare professionals that we demonstrate unity and collaboration in our goals and what we wish to achieve going forward, crossing borders, boundaries, respecting each other's worlds, religions, etc.
So you think that there is unity, or you believe that that would be the most ideal?
My experience has been that looking at meetings like this and going to meetings across the world, talking about global neurosurgery, there is unity. We engage with many different neurosurgeons across the globe who are collaborative and wish to engage jointly to progress on what we wish to achieve with global neurosurgery, which is equity of care in lower middle income countries. So I think there is unity.
Sorry?
I think there is unity.
Okay. Does everybody agree?
I can chime in. I just wanted to make sure that Ruby had a chance to introduce herself. I don't think I heard her introduction.
Okay, I'm the moderator. I'm Ruby Mahesparan. I'm in the Global Humanitarian Committee, EANS.
Yeah.
Thank you, Keith.
Yeah, and Ellianne, did you want to introduce yourself too?
Oh, yeah. Sorry. Yeah, so I've been moderating the last couple of webinars of the EANS. So yeah, I'm located in Curaçao.
Yeah, at one point, you know, you represented the entire workforce of neurosurgical care in Curaçao. 100%.
Yes. Yeah. At one point, exactly.
So yeah, I'll say something. So I'm so glad you started off with the definition of global neurosurgery, right? It's really about access to timely, affordable, and safe neurosurgical care for all. I think our profession is unified in some ways about patient care, especially neurosurgical care. That's just why we exist. But remember, I remember when I was going to these big international meetings, you've got these top gun surgeons Taka, he was an amazing surgeon. And you have other surgeons who's able to do this, masterful surgery, watch the videos. And it was really that one person that could do it. And it wasn't a team sport, although there's a team supporting that one person. The achievement came on the shoulders of one person. But global neurosurgery, when we're trying to improve access, it's a health systems approach. It really requires a public health approach, policymakers, researchers, academia, NGOs, industry, and it requires a team effort. It's impossible to achieve what we're trying to achieve through just even just surgical profession alone. We really have to come at it from a community standpoint. And in that lies the sort of essence of unity, and it's a team sport.
Thank you, Kay. It was a nice suggestion and your opinion. And I would like to ask Professor Servadei if you want to comment on the topic.
Well, yeah, the unity, it's necessary, as Abdes Samad knows very well. We have worked in the World Federation to get the unity in the way in which we were looking at the issue of global neurosurgery, and Key Park was one of the founder of the all ideas. But the issue now, it's unity can mean knowledge. We have to know what's going on. I mean, I have looked for the presentation I have in the future. I have looked at the different global neurosurgery section, and there are, I could count 28, but there may be more. That each of the 6 continental society has a section on global neurosurgery. Each of these societies promoting initiatives. Then I have counted at least 21 national society who have a group of neurosurgeons who are interested in global neurosurgery, also with different initiatives. So we have, let's say, maybe enough, but this enough is not connected. Those one who are working from US are not connecting with those one who are working from Europe. Those one who are working in Asia are not connected with those one who are working in US. And then there is Africa that I will like to know our Professor El Ouahabi opinion, but that Africa, it's also, the CANS has a lot of initiative. We have training centers founded by WFNS in many African countries who succeeded to increase the number of neurosurgeons. Then we have the COSEXA. Europeans are collaborating with COSEXA. Americans are collaborating in Tanzania, Uganda. So I think unity can mean that we cannot repeat things that are already being done and not doing what we need because we don't know each other. We need to work together. This is an issue that I feel mostly important.
Yeah, I think that is well said. I think that everybody wants unity and everybody is collaborating, but there is no communication. But please, Professor El Ouahabi.
Yes. Thank you for the invitation. It's very important. I think that the choice of the theme is very important. And you start with a very important question. What is the meaning of unity? It depends which side we are. That's the first thing. Now, unity, from philosophical point of view, we are, unified, if you can tell that. But in practical condition, there is no unity. This is, I think, the reason why there is global neurosurgical program, and this is why we created all this kind of program to try and not to lose our powers doing the same thing, maybe sometimes in almost in the same area. And Professor Servadei just said about that. We have been witnessing some kind of program that duplicating the same thing and having different results and sometimes some conflict between the two programs. Don't in practice, we should have this unity, but so far it is not. There is no unity so far. So we have to work on that. There is a lot of means. We try to make all these forces conversion for the same goal, is to give the same opportunities for neurosurgeons all over the world, and especially in low and middle income countries, the same opportunities that in the high income countries. Because in Africa, in low middle country, the meaning of global neurosurgery, the meaning of unity is so different. This kind of definition should be lived in practice. So we have to look for that kind of program that to have knowledge sharing, to have kind of advocacy for building programs, for helping infrastructures. This, we can say that this is unity. This is from my point of view, and this is what we have been looking for the last maybe 20 years.
Thank you very much for your opinion. It was nicely said. And I want to ask Nigel if you want to comment on this. Do you think we have unity?
Well,
We are doing something. Everybody is doing something.
yeah, it's interesting. Well, with the SBNS, we started global neurosurgery about 2 years ago, and I came at it with little knowledge, and I found it very difficult to know where to start. I was looking at the macro side of things. What can we do to really make a difference? And I found it very difficult to, where could I go to find the information where I might be able to help people? Which country needs our help, and not, as was previously said, not making the mistake of doing something else that someone else is already doing, reinventing the wheel. And I think we need a bit more joined up collaboration. So we are working, trying to build a picture, but not painting on the same spot. And I think the idea of perhaps, I think it's being proposed of an international Society of Global Neurosurgery may be another starting point, because that's already been alluded to. We spent 20 years trying to make a difference. And of course, a difference has been made, but it does feel as if we're still falling short. But as Professor Parker's alluded to, this is very much a team effort. And when I look at the SBNS, we're just a small cog in a very small wheel. And in going to the people that make the decisions, the World Health Organization, the World Health Assembly, ultimately you're going to need to evidence to persuade or demonstrate to departments of health in low and middle income countries that there is a need for development of neurosurgery. But it's just not a question of developing neurosurgeons, is it? I mean, a lot goes, you need intensive care, importantly, nursing staff. You just can't train a neurosurgeon to work by themselves. It's a very big picture. And then you could discuss whether neurosurgery itself, how important is it? And what does it deliver? We know traumatic brain injury is a major healthcare burden. But if you have a serious brain injury, if you don't have rehabilitation, it's not good. So healthcare prevention becomes really important. Then you produce the evidence that this is a cost to society by untreated head or poorly treated head injuries, and develop policies for prevention, like wearing seatbelts, wearing helmets.
Yes.
Would you like to comment on that, Dr. Park?
Yeah.
So you raised your hand earlier. I'm sorry.
Sure.
Yeah.
Yeah, so unity and purpose, right? When you have a purpose that's unifying, I think there's such impressive work that can be achieved. I'll give you some examples. I think Sierra Leone is a great example. This is where the Ministry of Health initiated it. WFNS, at that time, I was the chair of the Global Neurosurgery Committee. We brought together partners, talked to Abdus Samad, the Rabat program, accepted 2 residents, 2 trainees from Sierra Leone. Tariq's group sent instruments from Pakistan, and then the medical students are writing stories about it. This is the kind of activity that I think when you get everybody together and working towards the same goal, you can achieve some amazing things. Another example was when Franco Servadei started the Global Neurosurgery Committee in 2019 with Abdus Samad and myself being the co-chairs. We came up with a global action plan for global neurosurgery. Some of the objectives were to get major medical journals, neurosurgery journals, to have global neurosurgery sections. Every one of our journals now have that. We actually have a brand new journal Journal of Global Neurosurgery. What about that resolution asking for folic acid fortification at the World Health Assembly? That's a huge achievement, and that's everybody coming together. And now Tariq's working on the one, with Hutch at Cambridge, on the TBI resolution. I think we're going to get there. The problem is you need strong leadership to get unity. And this is where I think we have a serious problem right now at the WFNS level. We have no one there really pushing, supporting, or facilitating these amazing efforts by these groups.
So in that sense, would you say that a strong leadership in WFNS would improve unity and leadership? Is there still, is the core of the WFNS still there to continue and to catch that wave to surf on?
We need strong leadership, and I would argue that we don't have that. In fact, Abdus Samad and I came across barriers from the WFNS Foundation when we approached them for funding, and they were not even helpful. They were actually trying to sabotage it. Abdus Samad, you remember the conversation that we had, and it really made me uncomfortable. So not only are they not doing their job, and if we don't have WFNS leading, who else will lead for us? We have to have strong leadership, and that's who will bring together all the groups and then give us direction.
Do you think a registry, like we've talked about this in other settings, right? To have a registry where we know what people are doing, so you don't have 3, 4, 5 different groups going to the same hospital 4 or 5 times a year, right? And then not going to other places because of a language barrier or whatever. Do you think that is actually the answer?
Well,
to start with the registry?
If I can tell something, first, there is no substitute for the World Federation. No single continent can deal by itself.
Absolutely.
Even if there were problems, the problems has to be solved at the level of a body which, let's say, worldwide, a body who represents the world, which is the WFNS, which can be a global neurosurgical, as Nigel said. But whatever, we need a strong place where all these efforts should be discussed and put together. So the idea of the registry, Abdus Samad, remember, we discussed it in Tanger in a meeting that he organized about, I think it was 2019, if I don't remember bad. Exactly. In this meeting and in Cairo after that, we discussed the possibility, we started from Africa, to have a sort of registry where we should report all the activities which were taken by different university, different continent, different African groups, just to show what is been doing and what we can do to put the efforts together. So this it's started from Africa, but I think Ellianne is correct. We need a sort of registry where a depository where we have all the spectrums of activities. So I think the continental society like EANS or WNS, they can help. But Ellianne, I have to tell you clearly, like we don't speak to accomplish. We speak to see how the problem can be solved. Key Park spoke about the WFNS. I have tried to ask the EANS to collaborate for a registry of activities with no answer for 2 years. So I think I have sent a project. My colleagues from Spain have sent projects, nothing happened. So I think we need, Ellianne, talking about global neurosurgery doesn't improve neurosurgical care in the world.
No,
This
that's
is
very true.
to
That's very
improve it, we have to start from small things, understanding what we are doing and where is the first. So we can also take the good example and transfer to those one who are starting now. But if we don't do it, that's not working. I mean, it's so the ENS, the WNS, the CNS, the British Society, my society, the Italian society, each society should be asked to provide a list of people collaborating with Africa, Asia, and whatever. And we need to put them together. So Ellianne, please take care, because
I'll
these
take
are
it upon
what you are
myself.
asking. What you are asking is already there. We have to
Yeah,
do
yeah.
it. That's
No,
very
yes,
simple.
no, I understand what you're saying. Yeah, yeah.
Professor
I thought I will try again and
Ellianne,
let's discuss it. Yes.
Professor.
Yeah. It's very important what you said, Franco. It's very important to have this registry. But may I add something? We looked for the activities in Africa recently, and we found that some program has been initiated over there without any information, without any, at least, respect for the Continental Association saying, okay, we're going to this part of the country just for information.
Mm-hmm.
And we used to have this kind of information between colleagues, department that asking other department if they can go there and practice some kind of surgery or help. That should go through the Continental Association. It's very important. This is a way to harmonize what is going on. And this is one thing. The second thing, I review also some data about, for example, the number of neurosurgeons in Africa, the number of facilities. And I was surprised to see that the data is wrong and have been published in very, high quality neurosurgical journals. So we start for now study on with asking that the figures should be approved and should be accepted by all the second vice president of each area before they can be used as official data from the CANS. I think if you have the two kind of information, have the registry for the activities going through CANS and information from the data, what is going from through Continental, we can hope for a program that I am sure that will be very successful.
Thank you for that comment. I think it is very, very important to vocalize this so people understand that it's not just a personal wish to want to help, but you know, we need to go where it is wanted and where it is actually, you know, where it's appreciated, and that's, you know, not just invent stuff and enter where no one actually asked for it. So yes, that's a very good point. And that, having said that, I have a question. Maybe it's outside of this realm, but over the last few years, especially the African continent has been publishing a lot more, research and has grown within the global neurosurgery space, or the publication of research, etc. And I just wanted to ask you, the more and more I'm seeing the institutions themselves publishing without any, twinning or collaboration or anything. Is that something that, how can I say this? Is that the road forward? In the sense that, it's the African data. Africa is taking, the power back and publishing on their own. Is that something that
Well, it would seem to me that's a very good thing if they're taking control and independence.
Yes.
Isn't that part of our aim, is to allow them, help them do that?
Absolutely.
If they've now have the aptitude and it's good quality data, absolutely. I mean, I don't think they need to twin if they've flown from the nest and they're doing it independently. I think that's fantastic. It shows a great achievement.
Mm-hmm.
This goes back to the leadership issue, Ellianne, I think, whether it's data sovereignty, whether it's authority on who is providing guidance on workforce. We need strong leadership to help coordinate all this, whether it's surveillance and registry. But we're just doing it all on our own. But we do need some kind of guidance from a body. And like Franco said, there is no substitute for WFNS, but we haven't seen much in that coming out of them. I would love for them to take leadership in this.
So what do you think we need now? What are the steps we have to do?
Well, I think
by neurosurgical community.
Well, I think Professor Parks made the point that you need strong leadership at the WFNS level. It seems to be straightforward from that perspective. If the WFNS is the society that is going to define global neurosurgery and what needs to be done, then clearly leadership from that organisation needs to be found. Otherwise, it's going to continue as we've done and it will fail.
Well, about the question of improving the publication, the output of low middle income countries, we have seen a phenomenon, or it's the improving as two sides, as you said. One is the twin publication made by two universities together. We did the research that we publish in 3/4 of these, the first or last name are not from low middle income countries. And there is an issue about authorships in this common publication. As Abdel Samad said before, very often this sort of collaboration have the risk of improving the impact factor of a university who does not need it. My university does not need an improvement of impact factor or visibility or references. We don't need it. The African or the Asian, we have done with Asia, collaborators, they need it. So it's a sort of good partnership. We have very good example from UK, from the study that they are doing in collaboration with Asia and Africa on trauma, where the number of people involved from this country is overwhelming the number of people from high-income countries, and there is an understanding of the needs. Pretending that we do a one-year follow-up in Africa is a nonsense. We will never do it, because 1 year follow-up is impossible. So we need surrogates. And it has been done before. So we need to understand what's going on. I believe that there is a huge possibility. There have been many papers published. I have reviewed some recently from many African and Asian countries who are improving the quality of the paper, even without the twin university system. But we need to standardize, and we need to discuss together how to do it. There are ways in which, for instance, the reviewers have to work more, because usually the reviewers say the 3 sentences, change these and these and these, finished. But in some situation, we have seen that you need to help to rewrite the paper, which is not the duty of the reviewer. But if you want to help these countries, we have good example of people who is doing it. So I think we have to consider key part in the Journal of Global Neurosurgery, many sections in journals, but I mean, that's key is not an issue, having a global neurosurgery section somewhere where the target is improving the impact. The target should be improving the quality of papers coming from these countries, and how can we leave them work together. This is the way, in my opinion.
Yeah, I think if you want to change things in policy, advocacy, etc., you would need more data. So I applaud all the data that has been published and all the growth, because without that, you cannot change anything. If it is possible to do it without collaboration and being something local and having that empowerment going, I applaud that, absolutely. I would like to see more, to be honest.
Sorry,
yeah.
I mean, the issue here then is about how you, academic institutions start collaborating internationally, and what process do you go down to allow that, to facilitate that? I mean, you can't have, as Franco said, writing papers just for the sake of writing papers is not what should be done. But high quality.
Well, personally, I think it kind of depends on the type of research. Like, I am not in an academic center, but I'm still publishing. Yes, it is together with other academic centers, but that's just because I'm collaborating with them, because I don't have any medical students. I don't have any, I don't have the facilities, so we need to do something else. So that is the way that I am collaborating. Is that randomized controlled trials? No, but who says that that is the way to go? I mean, sometimes a survey is good quality data if, performed well. Even case series, if we are living in a world where we rely on data from Western communities, who says that that is replicable in Asia, in Africa? So I think it is time to get more data from all these continents that haven't had the opportunities to, because of publication bias, right? Because that, I believe, happens. purely based on your affiliation. So, but
Yeah.
please, Professor.
Yeah, I think the one of the reason that the publication that's coming from Africa is now being numerous when you compare with maybe the last 5 years or before that, there is some kind the colleagues there are like upset. I mean, when they try to work in collaboration study with the developed country, there is some requirements that are not possible to apply in doing studies in Africa. And they have many papers that have just rejected or blocked. So now it's like saying, okay, they are not care about us. Let's go on ourselves and work. This is like a reaction. You have if you have to feel, I mean, to understand that like a reaction that there is no unity. So let's go and work just doing it's we don't need sometimes in some kind of countries doing like prospective randomized study. There is what we call the science of practice. The
Yes.
science of practice is very scientific point of view. It's very important. If you go to a country with no means and they can show you what they can do with a very limited resources, this is some kind that has been to be accepted in high quality journal. Unfortunately, it's not. So this is the big problem. You have to work on that, either by asking some publisher to reserve a part in their journal saying this is, we are not responsible of the content, this is from their author, the authors is there, and this is just reflects their experience. That will encourage them to make better papers and work in the future with collaboration study. This is my opinion.
Yes, you are correct. I'm actually supervising a PhD student from Malawi, and just today we have gone through the data on hydrocephalus, and he had 680 children or babies with hydrocephalus. It's an enormous number. But the problem is, for me, working in a high facility center, they have nearly 30% died, 30% couldn't get the follow-up because you don't have the address, you don't have the telephone number, you don't have anything to contact these people. So it's kind of this is the normal thing in their country. But I think the data is still valid, what they have done, and establishing a center in 600 with 680 from nothing to so many patients. That's valid data, and this is good. But when you compare that with my center, this is not big science actually. But I think those who are reviewing these papers should take consideration of what type of settings these papers are coming from.
Sure.
So I'm so glad we're talking about research capacity building. You know, research is so important, at least for two reasons. One is that's how you improve, you know, the processes. But the other one is that it gives them visibility in the international arena. But here's what we need to do to build research capacity. You need to have a strategy, and then you also have to implement that strategy. I agree with Franco. Just having a journal is not enough. You have to figure out a way to help build research capacity. You need funding, whether it's, you know, recognition with some prizes or longitudinal funding through institutional type of grants. I remember when the University of Bergen co-applied with the Ethiopia, Addis Ababa University for these large grants. That's what they need. This is how we can be of help. So, you know, and then you also need to help with editorial capacity building. We want them to be editors of these journals, not just contributors of content. So you have to have a strategy around it, but you need, once again, I come back to this, leadership and execution capabilities. And right now, none of our organizations are working on this.
And the leadership needs to be from different angles, I would say.
Could be EANS, but it'd be good to have a global organization leading it.
No, I'm not saying, I mean, different angles. So different, you know, different types of countries, you know, different visibility, let me just say that. So not just try to go a selected group on top.
What do you mean, Ellianne? I'm not sure.
Well, if we're talking, like, I have a sense that the thread of the red thread through this story is trying to mix and match, right? If the beginning was all, you know, focused on Western and Northern, and now it's mixing. So now it's becoming more of a collaboration, and maybe that is also needed in the leadership at leadership level. That yes, it is a WFNS, but that also needs to be available for everybody to, you know, get to that leadership, if you know what I'm saying. Is it more clear? But still.
Yeah, there are a lot of levers that a global organization can push and pull, right? I mean, they could provide, let's say, financial support for a research project that requires collaboration between global South institutions, right? So they can put certain criteria that's designed to empower and drive funding and build capacity.
Yeah.
But when we talk about research strategy, okay, I'm not really an academic neurosurgeon. We talk about developing research strategy. Presumably, you know, that strategy needs to come from the ELMIC countries to help. There's no point in us saying, well, we think you should be doing this.
So I meant research capacity building strategy as a global organization. And then each country will develop their own research agenda, if you will, right? Based on what their needs and priorities are. Does that make sense, Nigel? Or?
Yeah, it does. I mean, there are. I mean, it's a bit. NIH are doing that with Hutch, you know, for the TBI. I know Lord Aradazi at Imperial with his Imperial Global Health Group is. You know, they're reaching out. The LSC, the Global Policy Unit, for example, the Royal College of Surgeons of England and Edinburgh. All the Royal Colleges are reaching out for that sort of joint collaborative research.
So there's a reason why Hutch's group, which is well-funded, has to have partners in LMIC, and that's a requirement by NIHR. And those are the kind of things that we can institute within our own communities.
But of course, it will then, you know, as you say, it comes down to funding, and we all know that's funding is difficult.
Yes,
certain parts of the world where funding has been withdrawn.
But if I can tell something, as Abdel Samad said before, one of the key issues is how do we do randomized clinical trials in low middle income countries? This is a key issue. Randomized clinical trials are evidence-based and transferred to guidelines. So we are denying guidelines produced by country who need them, because the most people who need the guidelines are in these countries, are not with us. So there is a sort of wrong circle where we cannot go out. The only way to go out is establishing different rules. The Bristol, the British group in general surgery during the COVID was the first one to publish papers produced all over the world where the only outcome was mortality before discharge. Finish. Very simple. All over the world, every country could contribute because the endpoint was easy. In another example, we have published, some of our American colleagues have published papers about not to place ICP monitoring because it's expensive. How can we measure ICP? By repeating CT scan. The only issue is in many countries, you cannot do 5 CT scans in a week. It will cost you more than doing an ICP monitoring. So these are all examples that we need new rules. We need to say that if we publish randomized clinical trials with these limits in this country, we can represent 2/3 of the world. It's reality. So we need data from 2/3 of the world, and we cannot say they cannot produce data because our rules do not work there. We need to help them to establish new rules. Very simple. It has been done already by the general surgery group linked to the WHO. They have changed the rules and they have published the paper in Lancet. So, and Lancet accepted it. So this is the way to do it, not in extemporaneous way. Establish new rules for randomized clinical trials in these countries.
That's a powerful message. And I fully agree.
Yes.
But Frank, who's going to make those changes? How do we convince people that it's acceptable to make those changes?
If there is no top, then we do it ourselves. It's the easiest way. So I think we are here in a webinar of a continental society. And we have two national European society, ourselves and you, the British, who are working in this field. And this is a powerful way to connect with the CANS, to connect with the WNS. We need to, in a way, make proposals and work together from the bottom. Then we are expecting big changes in the WFNS, if not in a global society. But meantime, we need to collaborate and work together and say our priority now is establishing, I give you an example, new rules for randomized clinical trials and publish all together following the same rules. Obviously, with the help of Abdel Samad, with the help of our ASEAN colleagues, who can tell us what they can and they cannot do. This is simple. But there is science in limited resort areas. There is science there.
Absolutely.
So
do you
presumably
think-
that could presumably, if the WFNS at the moment are able to do that, then the EANS and the academic committee could draw up those guidelines.
Yes.
Correct.
Well, there's a start. That's a starting point.
That's a good point.
And do you
Well,
think
that's
that
what
this
I-
can also be done for education, neurosurgical education for residencies? As that is also very,
Well, as the
diverse.
Latins say, one topic after the other. So now we work for randomized clinical trials, and after that we move to education.
Yes.
Ellianne, you are too
I
generous.
want everything at once. Yes, I know.
But with
Ruby, you
regard-
wanted to say something?
But with regard to education, I mean, is there a need? We've talked about this before, about a global neurosurgical curriculum, a basic level of training that accredits a neurosurgeon to work anywhere in the world. I mean, it's been an idea floating about having a worldwide accredited neurosurgical curriculum. I can see difficulties in that, what you need a neurosurgeon to do, not in certain countries, not necessarily
Yes.
high flow bypass surgery.
Yes.
You have to take out convexing meningia, standard, what the most common operation in the world, but for neurosurgery, burr evacuation of a chronic subdural. I'm not sure you need to train a neurosurgeon to be a neurosurgeon to do that. So where there is a lack of capacity.
Or have at least 2 tiers of neurosurgical training, like what Abdel Samad did with the Sierra Leone neurosurgeons. One gentleman was trained to do trauma and pediatrics, and he's already back after, I think, a year and a half, and is doing craniotomies for trauma and saving lives. And the other resident is staying on for the full training. Vietnam has that model already. They have two tracks. So that's something that we could all share, and then countries can decide what's best for them. We don't need to be prescriptive and say you should or this and that, but there's clearly a need for a more accelerated and more generalized neurosurgical training rather than this sort of do-it-all, functional to spine to vascular.
Yeah.
That's not good.
Mhm. I think we can maybe go for something that we can agreed upon, that say what is the minimum required to do neurosurgery. This, I think that should be like guidelines. This is the minimum, global minimum requirements. This is very important. And then there are like step 1, step 2, step 3. I mean, but we should have this kind of idea, what is the minimum requirements at the global level.
Once again, we need leadership to do that.
Of course.
Ellianne,
need-
sorry, I have to leave. The train will now wait. Thank you so much. Thank you for
Ciao.
inviting
For
me.
your
And
insights.
very, very wealthy discussion. Thank you. We need follow-up.
Yes,
Bye.
we
Hi,
do.
Franco.
Thank you. So I see we have a question in the Q&A. In some regions, cooperation with local military authorities is necessary for efficient delivery of care and training. What is the best way to use this approach, and what are the dangers?
Is there any military of the group today?
No.
We need maybe a military.
We need to, we to ask the military committee
Yeah.
to help us with this.
Well, I mean, maybe I'm not sure.
No.
I mean, in some reason, you would like to have help from other authorities where you have a lack of workforce. I mean, for example, in my area, it would be very welcomed if there is some, a military station somewhere that can do burr holes and emergency hematoma evacuations to save lives, because otherwise they die because no one is there to save these people. So in that sense, I would say maybe it would be an idea to have a cooperation with local military.
To my knowledge, there are many countries in Africa, they have their military hospitals with neurosurgeon over there.
Yes.
So
Mhm.
it's open also for civilians, not just for military. So
Okay.
I don't think it's a big deal. I mean, it's we're saving, I mean, lives, military or civilian, so it's the same. I mean, now
So maybe
I don't know if this is the question. I mean, that we meet the main of the question.
maybe the dangers might be, I don't know, a neurosurgery becoming a different specialty or something. I don't know what.
Yeah, I'm not
Lawrence
quite clear
Watkins
about
wanted to
the sort of
state.
direction of the question, because collaborating with military authorities, they've got logistics, vehicles,
Mhm.
helicopters. So that sort of collaboration is probably a good thing. If there's a suggestion that you have to, if you don't cooperate with local military authorities, you might be in trouble for whatever reason. Clearly, that is a danger.
Yeah.
So I've read that question two ways. The good way being collaboration with the military, which is a good thing because of the reasons I've given above. Then, of course, with local conflicts with military or other terrorist groups, clearly there's a danger in providing healthcare.
Mhm.
I
I mean,
thought
the other,
sorry.
no, I was just gonna say one of the potential risks, and not an expert in this in any way, is that if there's a conflict going on and you side with one group, you can offset. I mean, we should be impartial, right? We should be neutral. And we treat everyone, but then if there's a conflict, we might end up excluding another group entirely.
Hmm.
So we are nearing the end of our hour. I don't know if anyone wants to.
Would like to ask Key, because you were saying that the leadership is important. I agree totally with you. But till we get that leader who wants to do this tonight, I would like to ask, do you have any suggestion for EANS, Humanitarian Committee? What we can do to increase the unity?
So with the vacuum of leadership at the global level, EANS probably is one of the most active, continental societies. I don't see a lot of activity happening at the Australasia CANS. I think they're doing global neurosurgery, right? And and then Americas, I'm not sure we're doing anything except more outreach type of activity. But EANS could initiate as maybe some sort of a dialogue and provide a communication of all the continental societies, maybe even all the national societies, right? And try to at least come together on some key issues to collaborate on.
Professor, do you want to comment on this?
Professor Ouahabi?
Sorry, I didn't get your question. Sorry.
No, I was asking, do you have any suggestion that EANS, Humanitarian Committee or EANS can
Yeah.
use
Yeah.
to get more unity in?
Yeah. Good, very good question. I think we have to approach the African countries and asking three things: what they have already. They are now developing a lot of means and many department, what they have, what they are looking for, what they need. But also, very important question, it's for respect, what they can offer for the developed country.
Yeah.
This is very important.
Absolutely.
Their experiences in very bad condition,
Yeah.
their means, their patients maybe, but this should be clear. This is the kind of collaboration should be equitable. This is very important.
Yes, I totally agree. It's well said. Ellianne, do you have anything?
There's someone who put something in the Q&A. So this webinar is quite interesting for me as a neurosurgeon. Thanks to you all. How could a private practicing neurosurgeon who is not a member of any clinic can contribute to the unity in neurosurgery? What would be the suggestions and advices from your points?
Join your committee.
Yeah.
Yeah. Well, I mean, Key, you were a private practicing neurosurgeon before this whole global neurosurgery happened. So maybe you can share some of your thoughts.
Yeah, I volunteered to help teach in developing countries. That's where I met Ruby in Ethiopia. And then I did that for 8 years. And then kind of came to an epiphany saying, we need to go beyond just training. We need to think about the health system, the public health approach to improving and strengthening neurosurgical care system. So yeah, that's been my experience. Get a master's in public health.
Yeah, that probably helps. Okay, anyone else has closing thoughts? I think this was an interesting platform without presentations.
There's another question there, Ellianne.
Oh, sorry. Oh, yes. In most LMICs, there is no registry or digitalization of data. How can we ensure that the protocols and guidelines from high-income countries is applicable to low-middle-income countries? And if they actually adhere to it, especially in situations where the subject is neurotrauma or infectious or endemic diseases?
This is a really timely question, especially
Yeah.
given the fact that the TBI resolution is being discussed right now. If that passes next May in Geneva at the World Health Assembly, member states there'll be a number of recommendations that they have to sort of try to fulfill. And one of them would be, how do they do the surveillance, registration, measure TBI in their countries? It's a great question. I don't have an answer yet, but
Oh, and then Lawrence Watkins again.
This one.
it was just a nice
Nice comment.
advent. Yeah.
There's another question in the chat instead of the Q&A. So how can a last year medical student with a high interest in global neurosurgery contribute? Send a message. I think, let me see. You know, I will send you my email and then we can talk afterwards.
I just put my email on the
There
chat
you
too.
go. Yep.
Yeah, Ellianne and I are in the same lab, so if you
Yes.
come, either one of us, you'll end up in our lab.
Yes. That is a great way to collaborate. Yeah. And to contribute. Okay.
Well, thank you, Ellianne and
Thank you,
Ruby. This
Ellianne.
was a
Yeah.
really good
Yeah.
conversation.
Thank you. Very
Yeah, we need
nice
a follow-up on this.
Oh,
Yeah,
there's another one.
absolutely.
Can we have, all of a sudden, everybody, can we have an initiative for quality improvement and clinical audit based on their last brain trauma foundation for penetrating TBI? An initiative, quality improvement and clinical audits.
Oh, there's talking about the BTF guidelines.
Yeah.
Just came out.
Yeah.
Okay.
Okay.
I think you should do that, right? Check if the guideline is actually working. Okay. Thank you all for your time.
Thank
Pleasure.
you.
Thank you,
Thank you,
Ellianne.
you
Thank
all.
you,
And,
Great meeting, Ellianne.
Nigel.
Very
Samad.
Yeah.
Thank you.
you.
Bye-bye.
Bye.
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 Ciao.
Bye. Q.
Bye.
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 That was it. I think everybody left.
Yeah, the participants not, I think, but
Okay, it was okay.